The next lecture is mine, and that is about a very interesting topic, tuberculosis and diabetes, often not talked about. Though both are important, and co-infection is particularly important, it is something which is not often talked about in the conferences. A little bit of background here. Now, this is an article in Bloomberg Markets several years back. And one of the persons who wrote this article, Jason Gale, he went across India and looked at the people who are getting diabetes in India. This is one of the best articles from the layman's perspective, one of the best articles as far as diabetes in India is concerned. What he wrote was read by millions of people. What he said was that in land of now plenty, the diabetes is striking the low socioeconomic strata. He also mentioned that this is the socioeconomic strata where communicable diseases are also widely prevalent. So actually, two epidemics are striking the low socioeconomic strata: diabetes and communicable diseases, and prominent among those is the tuberculosis. Now look at this, the incidence of TB in top 8 countries in 2020. India continues to be at the top. Despite the National Diabetes Tuberculosis Program for several years now, we still are not able to contain. Look at the difference between us and China. Huge difference, huge numbers of people. So tuberculosis is, as far as communicable diseases are concerned, top priority for containment. And diabetes continues unabated. We know about that. This is written by one of my colleagues from Sri Lanka. And look at the graph, both for diabetes in urban areas and rural areas, and pre-diabetes now crossing. Now look at this. This is very interesting. Now pre-diabetes prevalence is crossing in rural areas versus the urban areas. So both epidemics are at full swing. Now, these are the risk factors associated with tuberculosis in India. And amongst, forget about the age, we know, we have all read this in the undergraduation, in the post-graduation, and so on. But what is more important is that the two yellow dots that I have put, and the yellow dots say BMI of less than 18.5 is a risk factor for tuberculosis. We knew that, but here is the reality, that this is where the diabetes is striking also. So diabetes becomes another risk factor for tuberculosis. Now, what is the biological plausibility of this? Very simple, very simple. Hyperglycemia begets decrease in the immune function, which increases susceptibility to infection. Infection occurs, which increases hyperglycemia. This is the biological plausibility. There are many immune dysfunction associated with diabetes, and immune dysfunction is also associated with tuberculosis. Both coexist together. So having diabetes increases your chances of tuberculosis. Now let's look at the diabetes tuberculosis comorbidity. This is the data from 2012, so a decade back, from a small South Indian center from the national program. 827 were sampled. Look at the diabetes prevalence in patients with tuberculosis, 25%, pre-diabetes 25%. But what is interesting to see is that BMI and waist circumference on patients who are not having diabetes versus diabetes, there's a slight difference here. So non-diabetic have lower BMI, lower waist circumference, diabetic, even a slight increase in the BMI in patients with tuberculosis may predispose to diabetes mellitus. And a decade later, a meta-analysis in the South Asian population, the pooled prevalence of diabetes in TB patients was 21%. So almost similar as compared to 2012, 21%. And from 11% in Bangladesh to 24% in Sri Lanka. There are many other facts that this meta-analysis revealed, including higher odds of mortality. I'll come to that a little later, treatment failure, and no association with the multi-drug resistant tuberculosis. Another interesting point is that there may be transient hyperglycemia when a person gets tuberculosis. And look at this. This is the patient with pre-diabetes. This is new diabetes and this is known diabetes at initiation of anti-tubercular treatment. And after 3 months, especially the pre-diabetes decreased markedly, and 6 months also. So these authors said that there may be transient hyperglycemia during tuberculosis and that this may decrease. So do not label these patients as diabetic till you have treated the patient for at least 3 to 6 months. A little bit about signs and symptoms. We are all clinicians. We see the patient. We should, whether the patient with diabetes and tuberculosis have different signs, symptoms of tuberculosis. And this was pointed out way back, almost 100 years back, by Sosnam and Sotostidal, that large proportion of patients with diabetes have lower lung involvement with tuberculosis, multi-lobar involvement and multiple cavities. And if you look at this, you see, look at the bilateral involvement here, lower lobe involvement as far as diabetes is concerned. Now this is a data from India. So all what I am presenting is from India. So there is no international data in this presentation. Now look at the symptoms here. If you look at the symptoms, hemoptysis is more common in patients with diabetes. Weight loss is also more common. Mycobacterial burden is 4 times high, and each % increase in the hemoglobin A1C level associated with higher mycobacterial burden. Radiological disease is higher, though statistically not significant. And look at this again, the lower lobe lesions are higher and cavitary lesions are also higher. And risk of TB transmission to close contact may be higher from TB patients with diabetes rather than those without diabetes. What about the outcomes? Let's look at the outcomes. And this is the 2013 data from Dr. Vijay Vishwanathan's group. Sputum culture positivity at the end of intensive phase is much lesser with patients with diabetes. Sputum conversion is lesser. Treatment failure is higher. Here, multi-drug resistant tuberculosis was a very small number of patients, but previously I had shown that the meta-analysis showed that there was no increase in multi-drug resistant tuberculosis. And then subsequently, a decade later, if you look at this, this is another data, 799 participants confirmed tuberculosis. And look at this, the composite outcome failure, which is failure recurrence, mortality was 20% in patients with DMTB versus 21%, so not much of a difference, but mortality was higher. And early mortality was particularly higher. And those who have new onset diabetes, this is the new onset diabetes versus no diabetic, and there is known diabetic, new onset diabetes had a particularly high early mortality. What about the screening for household contacts of tuberculosis? This is a very interesting study. We showed that if you screen for household contact of tuberculosis, then you'll find many patients with diabetes. And so 37% prevalence of pre-diabetes and diabetes combined in patients' household contacts. And out of which 27% were pre-diabetic, that is the second marker, and 10% had diabetes. So it is imperative that a person with tuberculosis should have the family, the whole family household contact should be investigated for diabetes. Now what about the drugs for management? What would be, I will ask our learned clinicians here, in a patient with say multi-lobar tuberculosis, and diabetes, what would you use for control of diabetes? Dr. Israni? Insulin.
Insulin, obviously, but as it is, TB is also nowadays, what we are seeing is MDR. It becomes a maintenance, and insulin obviously is the drug of choice. That way we can.
Any other different opinion? No, I'm not asking about that. I'm asking about which drug will you use. Insulin has been answered.
Insulin, metformin.
Thank you. Now there is some new data here. Concentration of, so let me just talk about everything. Concentration of anti-tubercular drug in patients with DMTB versus those with TB alone, there is low concentration of isoniazid and pyrazinamide, and not affected is rifampicin. Isoniazid and rifampicin may interfere with metabolism of sulfonylureas, thus decreasing its level. Rifampicin may itself cause hyperglycemia. There are overlapping toxicities, peripheral neuropathy with diabetes and INH both. But what is interesting is this. Look at this, Dr. Israni. Metformin, there is ample data now, decreases mortality, reduces risk of recurrence of tuberculosis, decreases matrix metalloproteinase levels, hence may decrease destruction of pulmonary tissues. Even in thin patients with tuberculosis and diabetes, metformin has to be used. This is the difference from the previous opinion, and now I'm using metformin. Previously, Dr. Israni, I was using only insulin. Challenges, there are multiple challenges here. And these are some of the studies done in India, operational study. You look at this, that we have failed as far as diabetes control is concerned in patients with tuberculosis, although bidirectional screening, those with diabetes, tuberculosis screening, those with tuberculosis, diabetes screening is going on. And that is a WHO directive. Only 24% was screened under the national program. And behind that, low patient awareness, poor knowledge of guidelines among the healthcare providers, lack of staff, inadequate training. These are barriers for the correct screening of diabetes. Not only screening, but also for the management. And look at some of the statements. This is again operational research. And look at the statement which are revealing. Government says we are doing enough tests, but you know what is happening at PHC? There's no specific program for control of diabetes. This is a real problem. Bihar, whatever human resources are available for TB should be fully devoted to TB management, that they are assigned to many other duties, and therefore we cannot optimize TB case detection and management. Bihar, healthcare facilities face manpower shortage. There's no doctor and front-level staffs are stretched. There's no sufficient sputum microscopy gene expert. How will we diagnosis happen? As a government official, I can't say much. But if you go to the field, you will see for yourself. This is the current state of affairs as far as the control of TB as well as diabetes. So we need stronger political commitment for strengthening individualized programs, the effective integration of general health system through better horizontal, vertical strategy, better district TB-DM programs, and closing the training and skills gap, resource mobilization, and strengthening the data system. There are 3 epidemics which are going on. Diabetes, we had seen during COVID time, diabetes was uncontrolled totally. Patients were totally uncontrolled, new onset diabetes increased. Tuberculosis, there was interruption of national TB program, a suboptimal treatment of tuberculosis during the COVID times. So convergence of 3 epidemic, and we are devastated. We see results today of those 3 epidemics. So this is the summary. Diabetes and TB are both highly prevalent in India, coexist in substantial number of patients. TB and DM may present in atypical manner with high mycobacterial load. Treatment failure and mortality may be higher in TB-DM cases as compared to TB alone. Detection and bidirectional screening is warranted in an aggressive mode in India, and use of metformin should be more liberal in patients with TB-DM in addition to insulin, and that may impact mortality and recurrence favorably. Thank you.
Thank you so much, sir. So we have one question for you from Dr. Israni. Relationship of HIV in diabetes with TB is becoming common, especially in MDR and uncontrolled in low socioeconomic status. So what do you see and how to go about it?
About the MDR?
MDR, HIV and diabetes.
This is interesting that while we have higher mycobacterial load in patients with TBDM, patients with TBDM do not have much of the higher MDR load as per the data. But very interesting that the one paper shows multiple mutations occurring in the mycobacterial genes in patients with diabetes, new mutations occurring. So we'll have to carefully watch. I am afraid there's not enough research in this direction, and this is something that we should do because these are very difficult to treat as far as tuberculosis is concerned, and if diabetes is also not controlled, the recovery will be delayed and mortality will be higher. Thank you.